So before MCSP came on board, we were conducting routine immunization without a plan. We'd just go to our random outreaches and would immunize without even recording, because we never used to carry child registers to outreaches. We'd just tally and come back. Sometimes we'd even find there are no children, and the health workers would sit 2 hours and they pack up and come back to the facility. So our coverage was very poor, our utilization was very poor, and we're constantly in category 4. Yeah, MCSP came in and helped us to map. We were able to know which villages were supposed to serve. We were able to know the catchment and the target population. So we knew where to go and to get the children. Also, they equipped us with knowledge and skills through training. We were able to develop our own micro plans that suited our facility. Yes, we were able to use data tools because we were able to have a separate register for static sessions and outreach sessions. So all our children were being tallied and recorded in the child register. Yes, it helped us to improve our data greatly. Also, we're able to use our own data at the facility level, because formerly we would just collect data and submit to the district. It wasn't helping us as a facility. But when MCSP came in, we were able to use our own data to make decisions and actions wherever we found gaps. So the PDSA cycle, first of all, we were able to identify our broad problem, which was poor access, poor utilization. So we then proceeded to use the fishbone analysis to find out our gaps, what was causing this. Yes, so we identified many different gaps: poor data documentation, poor use of data tools, lack of use of data. Some of the outreaches were not functional, poor mobilization. So we got the different gaps and were able to get solutions or actions that we could take to bridge, to close those gaps. Among those, we were able to develop our child registers in villages. So each village had its own specific pages. So if a health worker goes into a register to look for a child, they knew where to go and where to get that child. Also, we have 2 child registers now, one for outreaches and one for statics. So in case someone is out for an outreach and you receive a child at the facility, you're able to record. Yes, we also did child registration. This was done by VHTs, who were provided with templates that they recorded the children. So we knew who was out there and their immunization status. So we were able to follow up on the children that had not completed or had defaulted, or those who were on schedule. We were able to know if they got the subsequent shots and completed. This is an approach that we developed in one of our quit meetings. We realized we hadn't hit our target and time was running out. The month was almost ending. So we looked for a quickest solution to be able to get those children. We divided ourselves, the health workers that were present at that meeting. We assigned them a village, 2 villages per health worker. So immediately they went down and looked actively for those children. So by the end of the month, we were able to recover whoever had missed their sessions, and we adopted it and carried it on, and we are still using it. From the time MCSP came on board, within 3 months, we had improved from category 4 to category 2. In the next 3 months, we were in category 1, and we have been there since. Our measles coverage was also around 45%. We are now at 89%.
So now when MCSP came in, they gave us an orientation, a training in the attributes of leadership, management, and accountability. After that meeting, I realized that what was missing in my facility was those core values of leadership and management. That is delegation, that is teamwork, and effective communication. I had to go back and reorganize my team by convening a staff meeting. I delegated my responsibilities of an in charge, like assigning health workers villages to be responsible for, as in getting these targets and reaching every child, and then report to me. I delegated them the use and spending of funds, PHC primary health care funds, and then they would only report to me at the end of the month their findings, their challenges they have faced, and then we would sit as a team and discuss. One, of course, I found there were no use of data for planning. So in order to make them feel the gist of our situation, I used to extract data and show them this is DPT1 coverage. We are at 75, we are at 80%, and the desired coverage is 90. This is what we have reported. We need to reach there. And even use the simple diagrams like graphs and the rest, and everyone would see. Then with delegation, when of course they would sit back and see that that is the responsibility of an in charge. But the moment I started making them touch the little funds, the little resources we had, pay and implement and give me accountability and tell me the challenges, they also realized how good it is to be responsible, even for the little resources you have. So along the way, they became motivated. It wasn't now my business as an in charge, but everyone's business, and in the long run, it built a team. My facility, Kitondo Health Center 3, my former facility, it is on the teamwork that is making us achieving all what I've narrated. I would still use the attractive way of communicating both to my staffs and the community, like using the pictorial way of expressing our ideas, like using a diagram of a fish bone to make everyone understand what we are trying to achieve. And after implementing that, in 1 quarter, believe me, our coverage improved from improved from category 4 to category 1. Our DPT1 coverage shoot up from 80 to 111, and our DPT3 coverage from 59 to 109. And then after getting these results, everyone was happy. We went into a meeting, and then I saw it working for us. I decided now to share this with our non-health stakeholders in our catchment area, like parish chiefs, like sub-county chiefs, chairmen, and also church leaders. In the same way, I also engaged all the facility in charges within my sub-county, and we started through mentorship and supervision of the same best practices in leadership and management. And going through 1 quarter, my sub-county, which used to be in category 4 all the time, now improved from category 4 to category 1 with all the 2 health center 2s and 1 health center 3, which is a PNFP. They all went into category 1. And surprisingly, because of that innovation, I was identified and picked up by the district to now go to a health center 4, become an in charge, and then implement the best practice at a sub-district level.
And Maternal and Child Survival Program came in at a time when Bushenyi had been displayed in the newspapers as one of the worst performing districts in category 4 regarding routine immunization. And Bushenyi, having been among the best districts all this while, it had always been ranked as a model district. So this prompted so many people. So many questions were raised by a lot of stakeholders, especially the politicians, because it was an embarrassing situation for Bushenyi to be among the least performing districts. So what happened, we had to team up. We had to involve the COW's office, the DHO's office, the RDC, and the political wing. We had to go down to the sub-counties and parishes to see that we have something done to elevate us to a higher level. And good enough, Maternal and Child Survival Program came in, and we managed to work hand in hand with them, which brought us to category 1. And we've managed to be at category 1 for the last 1.5 years. And what has been the trick here? We teamed up as stakeholders, as non-health stakeholders, and patterned in routine immunization activities. As a council, as a district council, they came up with a resolution to say that we have 5% of our local revenue addressed to handling routine immunization activities, among other health activities that were going on. We had other health activities like family planning, the youth livelihood corner. So that portion of 5% was meant to handle all the activities, routine immunization inclusive. And the sub-counties were also compelled to contribute 1% of their local revenue towards routine immunization. Together with the political wing and the politicians, there has been a lot of demand for results. Now that there was a resolution in place, we had to demand for results from the what? From the health units. The Secretary for Health was given that responsibility to see that communications are made with results to the district executive committee, which had those reports shared with the district council. Now that there was a resolution in place, we are compelled to account for the activities that are now going on. And this has been done for the last 1.5 years, and these results are being shared in council, and where things are not going well, those issues have been addressed. For example, the SASs were brought on board, whereby we had to make an activity as an innovation of support to routine immunization. And what is expected of them is that they need to share the quarterly meetings for routine immunization, share the reports that are brought to them, and at least see that they make some follow-up and see what is being done on the ground to effect the routine immunization activities. We are forced to bring the parish chiefs on board as well to see that they also come in as supervisors, do the support supervision at the parish level where most of the immunization outreaches are found. And we also expect them to report to the sub-county TPC, where reports regarding routine immunization are shared before being brought to the district. And the parish chiefs were also co-opted as members of the Health Management Committee. So it's there that most of the challenges have to be addressed and shared when it comes to TPC at the sub-county. We also had to change the communication. Previously, the health in charges used to report directly to the DHO. But this time round, they were compelled to report to the SASs at the sub-county so that information is shared right from the sub-county to the district level. And before reporting to the DHO, the SAS already has a copy of the routine immunization activities, which is also submitted to the COW's office. So at the district review meetings, routine immunization review meetings, we have two different reports, one from the DHO and another one from COW's office. So that means we have to compare and see if there is some consistency. And that is what has given us the push to maintain the category 1 of routine immunization. It's that push whereby we are supporting them with our 1% and 5% local revenue contribution, and the sub-county chiefs being brought on board together with the parish chiefs, and the district council being accountable to the district council now that it has come up with a resolution to support routine immunization.